All right, good morning. It's great to be here. And as Anthony said, we're going to focus a little bit on sports concussion for the next half hour or so. I have no disclosures, and I am part of a big team. We are a group at UCSF Sports of concussion docs who take, concussion doctors, physical therapists, athletic trainers, research scientists, physical therapists, all of whom focus on the clinical care of patients with sports concussion. And in talking about this, I think it's also important to acknowledge that sports concussion is just a small part of a big area of research on traumatic brain injury. In 2013, the CDC estimated that there were 2.8 million traumatic brain injuries in our country, the vast majority of which are mild traumatic brain injury or concussion. And that year, the CDC published the most common causes for traumatic brain injury, which you see here. The leading cause is, of course, falls, followed by a category called struck by or against an object. And so sports concussion is a subset of the falls and the struck by or against an object. And those of us in primary care know that falls are the most common cause of concussion in our patients, particularly those 65 and older. And then we'll focus on sports concussion today. I wanted to bring your attention as PCPs to this publication in the Annals of Internal Medicine in 2018, where the authors said the importance of the primary care physician in the timely diagnosis and optimal management of concussions cannot be overstated. And the CDC published this guideline in 2018, which was the first guideline in our country for kids with concussion, really outlining a few take-home points for primary care clinicians in their care for kids with concussion. And so we'll touch on some of these as well today. What I wanted to bring you are some updates that are on kind of the forefront of my mind this year with concussion. We're going to talk about the importance of history, the key tools in concussion management, the term of persistent post-concussion symptoms, which is what we're now calling what we used to call post-concussion syndrome, sort of tongue twisters. We're going to talk about exciting research around exercise and how that's being used in concussion recovery, and also a framework to use when you're talking with an athlete who's had a number of injuries. And so let's talk about the importance of history. I'm going to present 3 cases to you, and these are just going to be rapid-fire cases where you'll give me some information via ARS. So let's start with this one. This is an 18-year-old collegiate volleyball player who saw me 2 days after she was hit in the head by a volleyball. She told me that her head felt sore during practice, but she played through it. She took ibuprofen when she got home, and the next morning she had a headache. She presented to our athletic trainer for evaluation, and the athletic trainer was concerned she had a concussion. And so with your ARS clicker, what would you say? Does this patient have a concussion? Yes, definite concussion. B, probable. C, possible. Or D, nah, not a concussion. All right, so okay. So some disagreement. So some folks think possibly, probably, and maybe definitely. All right, so how about this case? This is another one of my patients, 20-year-old, brought in by her mother for concussion. The patient was a little unclear about why she was in clinic, but she reported having fallen from her bike 3 weeks ago, hitting her head and her right shoulder. She had no loss of consciousness nor amnesia, but she had trouble remembering the date of injury other than she could tell me it was a Saturday. She developed a headache and blurry vision within hours of injury. She had seen me in the past, so she saw me in 2016 when she had a concussion playing soccer. She also saw me in 2014 for a soccer-related concussion. The 2016 injury, it took her about 6 weeks to get better, and it took her 3 months to get better from the 2014 injury. She has no past medical history of migraine. She has no reported psychiatric history, but I noticed on her med list she was taking olanzapine. She told me she used marijuana in high school, but none recently, and used occasional alcohol. She said like 2 beers when she was out with friends. So I talked to her mom because, as you could tell, the history wasn't totally clear from her. She gave me permission to talk to her mom, who came back. She told me that the patient had started college in the fall, but wasn't able to complete college because of trouble with friends. And then she was actually evaluated in the emergency department near college for an episode of suicidal ideation, and that's when olanzapine was started. The emergency department had recommended both psychiatric and psychological follow-up, but that, of course, was difficult to arrange and then ultimately didn't happen. And so the patient and the family had stopped the olanzapine. And more recently, the patient had been attending a local community college, but since she fell off the bike 3 weeks before seeing me, she had developed unusual behavior, really a lot of irritability, confusion, and headaches. So her parents recommended she resume olanzapine and see me. So does this patient have a concussion? Yeah, definitely. B, probably. C, possibly. Or D, not a concussion. All right. So folks, this is more skewed toward yes. Sounds like, all right. So let's look at this third case. Another 18-year-old college athlete. This is a basketball player with no past medical history. He was hit in the face and fell to the ground. He hit his head on the court with 30 seconds to go in a game. He actually played the last 30 seconds, and the athletic trainer really didn't witness any loss of consciousness. The athletic trainer was right there on the sideline. And then the athlete couldn't recall what happened. At the end of the game, he asked the athletic trainer to evaluate him because he thought he might be concussed. And then he actually asked her again because he had forgotten he had asked for help. So due to amnesia, she took him to the emergency department. He was evaluated. He even had a head CT, which was negative. And one day later came into my clinic with his athletic trainer, and he was like, "Dr. Center, I feel fine." I was like, He's like, "I have no headache. I slept a lot last night. I've done schoolwork today. I've been in class. No problem." And he is not taking any medicine. So does he have a concussion? Does he definitely have a concussion? Probably, possibly, no. All right. Thank you. So, I'm sure that, in your practice, you encounter cases like this as well. And these three cases are just meant to highlight that, the history is key. The history is key when we see these patients. And so what is a concussion? It's still a clinical diagnosis. And it's important to remember as primary care clinicians that not every patient with a headache, confusion, dizziness, and mood change has a concussion, right? So this can be many other things. I've had patients with those symptoms who have a primary headache disorder, who have sinusitis, who have a substance use disorder, who have a primary psychiatric illness. And so to keep your differential really broad. But there are things that increase the likelihood of concussion. And so what are those things? Yeah, some kind of trauma, right? What else? There are other things where if someone tells you, "Oh yeah, this happened," you'll be like, "Yeah, that's at least a concussion." Amnesia and loss of consciousness. So if you have either of those, it's at least a concussion. That's not necessary for concussion, but you know that if that happened, they at least have a concussion. And then a few other criteria. So the symptoms, when you have a trauma, the symptoms of concussion should come on within a day or two of injury. And so really diving into that history with the patient, hey, when did the symptoms start? How long between the index trauma, and are you sure there was a trauma? And then also, the symptoms should be improving with time. So if you're seeing them a week post-injury, they really should be getting better little by little most of the time. So there's been a lot of work on this done, mostly at UCLA, and they've proposed this schema, which I present here: definite, probable, possible, and not a concussion, and thinking about how to really define this better, put a finer point to your clinical reasoning. So how do you figure out the likelihood? Well, thinking about these points that I just made, was there a mechanism, yes or no? Are the symptoms typical of concussion? So was there loss of consciousness or amnesia, which are obvious, and then, or are there a number of other classic concussion symptoms? That gives you a point. Were the symptoms within 24 hours? That gives you another point. And is the time course one of improvement? And is there an alternative diagnosis? So just putting a framework to the clinical reasoning that you do. And then thinking about, okay, well, 4 out of 4, yeah, that's definitely a concussion, or the opposite would be 0 out of 4, and there's some alternative diagnosis. No, that's not a concussion. So in this case, our 18-year-old volleyball who came in after being hit by the ball. So, she had a witness mechanism. She had typical symptoms. She did have a quick onset of symptoms. She wasn't really improving by the time she saw me. It was 2 days later. That there are different reasons why that might be. But, overall, I'd say, okay, given this schema, yeah, probably that's a concussion. My 20-year-old patient who fell off the bike, she had 3 weeks of ongoing symptoms. So did she have a witness mechanism? Not really. She could kind of tell me about it, but it was a little kind of hazy what had happened. Something had happened. Did she have typical symptoms? Yeah, she had a headache. She had confusion. Her symptoms did come on within 24 hours. She was not improving, and there might have been something else going on. There was a lot going on there. And so possibly she had a concussion. Possibly there's something else going on. And this 18-year-old basketball player with amnesia who presented to clinic within 24 hours, totally better. What was that? So he had a mechanism of injury, typical symptoms, onset within 24 hours, improving time course. So, by this schema, I would say definite concussion. And these are interesting cases. I think you probably also have seen cases of this where people get better very quickly. We always worry that the patient may not be telling the truth, of course, in these situations, and so you have to dig deep and make sure that they are. But I would say in this case, yeah, that's also a concussion. So the importance of just really thinking about your history. Other key tools in sports concussion management. So looking at that first case I presented you, that 18-year-old college volleyball player who was hit in practice with headache. So how do we manage this case? And I'll ask just for you to yell things out. What are key things to do when you see this patient in clinic? A neuro exam, yes, totally. I totally agree. So neuro exam, right? You want to just rule out an intracerebral hemorrhage, make sure that the patient doesn't need head imaging. I'd say also a neck exam. The evaluation we recommend is a 3-pronged evaluation. So looking at symptoms, neuro exam, neck exam, and mental status. If you don't already have a system for your evaluation, I'd suggest using the SCAT-5, which you can Google for the complete document. It's nicely organized. It gives you everything you need, a nice symptom checklist and prompts to look at memory and balance. The balance exam I wanted to highlight here, which we use in concussion, has been validated for concussion use. It's called the BESS, which stands for the Balance Error Scoring System, and you see that pictured here on the right. It's really 6 stances, and the athlete holds each of these for 20 seconds with her eyes closed. In clinic, we mostly just use the modified BESS, which are the top 3 stances. The complete BESS also includes 3 stances on a foam pad. So if you really want to challenge someone, you can do that. But we find the modified BESS to be quick, efficient, and useful. And so we'll do that as someone's getting better. And it's just a nice way to double check, especially your student athletes where you're wondering if they're ready to go back to sports. They should have good balance. And there are published norms for kids and their modified BESS scores. So another question for you. So on average, how quickly do adults with concussion recover? They recover in 3 to 5 days, 10 to 14 days, 3 to 4 weeks, 5 to 6 weeks, 2 months, or 3 months. All right, so people favor the lower time course, looks like 3 to 5 days, 10 to 14 days. We're sort of split there, 3 to 4 weeks. So the correct answer is in adults, it takes about 14 days to get better from concussion. So 2 weeks in adults, up to 4 weeks in kids. It's interesting, most of the time kids get better faster than adults, but in concussion, kids take longer. And so the CDC, one of the really principal recommendations in those 2018 CDC guidelines for mild traumatic brain injury in kids, one of the key recommendations was this part about counseling patients and families. So there's this interesting body of literature around concussion that The sooner we see these patients and the more quickly we can reassure them about their recovery, the better people feel. And so to build that into your first assessment and plan is a piece about counseling and reassurance that on average, adults recover in 14 days and kids in 4 weeks. These days, we're recommending a couple days of rest after a concussion. 1 to 2 days of rest, really low-key, not doing much, and then gradually adding back activity. And this is a bit of a shift. It used to be that we'd recommend really rest until you were asymptomatic from your concussion. But the data around rest is mounting, showing that if we rest you for too long, you actually become worse. And so right now, the recommendation is to rest for a couple days until you feel you can do a bit more, and then to gradually return back to some cognitive activity. And so what that looks like is, a simple kind of stair-stepping protocol. There's no right way to do this. It hasn't been well studied. But what I counsel patients about is to rest for a couple days, and when they feel up to it, to start resuming some cognitive activity. So some work, some screen time, some reading, and little by little, as they can tolerate more and more at home, they can start going back to a half day and then a full day of school or work. And depending on the person, I might recommend they set a timer at home and say, do 15 minutes and take a break, then do a bit more, just building up the same way, training cognitively the same way you would train for some kind of physical activity. The other rule of thumb we use for patients that I think patients find helpful is the 2-point rule. And I will say that this has not been published. This is just something a lot of us do in concussion, which is to say that if you have a headache and you're walking around, your headache's like a 3 out of 10, you start trying to do some cognitive activity and your headache goes up 2 points or more, so to a 5 out of 10 or more, then to back off. So that's your rule of thumb. So it's okay to, after a couple days of rest, to go back to some cognitive activity as long as the symptoms aren't exacerbated. Return to play is one of the hottest topics right now, I think, in sports concussion, and thinking about how early is it safe to exercise after concussion. Because there's data coming out showing that it may be actually even beneficial to exercise after concussion. I will say, I think that data, it's a little early to apply that widely, and the current guidelines still recommend not starting the return to play protocol in earnest until the student athlete is asymptomatic. Certainly our state guidelines still say that. And so I think when you're counseling a young person, I would still be conservative and not clear them to start a return to play protocol until they are asymptomatic. I do think, though, the guidelines and the data is starting to support a little bit of wiggle room in the early stages. So when we think about maybe an adult who's 2 weeks out from a concussion, still a bit headachy, the data would say it is safe for those folks to do some walking around, even some stationary bike, again, using the 2-point rule. So some cardio, even in the early phases of recovery, data would say is safe to do. Now, what about folks whose symptoms are not getting better along that timeline? So again, adults, we expect 2 weeks, kids 4 weeks, but sometimes we have patients who aren't getting better that quickly. And the term that's now being used to describe this is persistent post-concussion symptoms rather than post-concussion syndrome. And the reason is that syndrome sounds like it's a well-described sort of disease, and I would say, and it's really not. And in fact, it may be that these are, individual symptoms that are indicative of some other process. So not a syndrome, but what process do these symptoms represent? So I'll describe that to you in the context of another one of my patients. So this is a 44-year-old mother of 3 with a history of ADHD, anxiety, and depression. She fell while ice skating at a rink 3 months before she saw me, and she hit the back of her head. She wasn't wearing a helmet, and she may have had a second of loss of consciousness, but no amnesia. Since then, she had felt persistently fatigued and foggy and dizzy. She really needed to rest, she told me, like 90% of the time. She was very limited by this. She felt overwhelmed around her kids. She had to take breaks from being around them. She was unable to drive, and she was having trouble with her short-term memory. We did a SCAT-5. This is her SCAT-5 symptoms score. So this, I'm sure, is too small to really read, but you can see her circles really span the high numbers. So the SCAT-5 has 22 symptoms of concussion, and it's a Likert scale going from 0 to 6. And she is high, so she's 3 months post-injury, and her symptom severity score, when you total up all these numbers, is 68. And she's sort of clustering in headache and cognitive issues and mood and sleep. So this is persistent post-concussion symptoms. And the emerging concept, the emerging theory about best practice to evaluate these folks is to try to characterize the sphere in which their symptoms live. So are her symptoms primarily autonomic, or are they vestibulo-ocular, or are they primarily cognitive, or are they primarily emotional? And I think this, a lot of, concussion care is good primary care. It's a lot of sleuthing, and it's a lot of trying to figure out where the leading edge is in these patients and figuring out what's driving this, what's the root cause of how she's feeling. And then to develop a really individualized, targeted treatment plan for her. So I'll walk you through each of these. So how do we think about autonomic problems in persistent post-concussion symptoms? Well, a patient with autonomic problems, they might have orthostatic vital signs. They might tell you, if they're an exerciser, they might tell you, hey, my heart rate is way higher than normal. I'm just trying to jog on the treadmill and my heart rate is sky high. That's weird for me. That's an autonomic dysfunction. They might have an elevated resting heart rate. They might have large but reactive pupils. And in these folks, we recommend the 2-point rule, as we talked about. And this is where exercise can play a really key and helpful role in recovery. And we'll talk a little bit about that in detail. Vestibulo-ocular dysfunction is a really interesting part of concussion. And it may be that this affects up to 75% of our concussed patients. I think in the majority of patients, these things resolve on their own quickly, but in a subset, they do not, and they can be the root cause of these persistent post-concussion symptoms. Dr. Chang is going to go into detail on evaluating vestibulo-ocular symptoms in her workshop later today. But the idea is, as you may know, is to evaluate how the eye motion is. So doing saccades with the eyes going back and forth and up, down, looking at near-point convergence, looking at balance. And depending on the dysfunction, you can give particular modifications for school and for work. So these are vestibulo-ocular patients might tell you they feel dizzy. They might tell you that they're having trouble reading because their eyes moving side to side or up, down from their notes to the chalkboard causes dizziness or headache. So in your patients who are having struggles with reading and work, think about vestibulo-ocular dysfunction. When you identify that, if they screen positive, they can benefit from simple home exercises or working with a physical therapist who has an interest and expertise in rehab for concussion. Cognitive problems also, of course, are frequently reported in concussion, and usually you pick this up with the symptom report, sometimes with your memory testing. And rehab for this really involves just gradually getting back into cognitive activity little by little, using the 2-point rule, and very rarely will prescribe medications for this, something like a stimulant, but that's in exceedingly rare cases. And lastly, emotional problems. Emotional problems are really one of the pillars of concussion. Concussion almost always affects someone's emotions, and whether or not that lasts a long time depends on the person, but we will almost always screen our patients with persistent post-concussion symptoms with a PHQ-9 and or a GAD-7 and follow those serially. These patients, as you know, in primary care benefit from really good longitudinal follow-up, having a clear plan and reassurance that you know that they're going to get better with rehab. Empathy, sometimes, if you have access to it, cognitive behavioral therapy, and sometimes medication, depending on the patient. So those are sort of the pillars of how we evaluate a patient with persistent post-concussion symptoms. And I wanted to highlight in particular autonomic dysfunction because it brings out the potential benefit of exercise for concussion recovery. So this is the topic of progressive subsymptom threshold aerobic activity after a concussion. The idea is that exercise intolerance after a concussion probably reflects impaired autonomic function, and exercise improves autonomic function. And there is emerging data suggesting that subsymptom threshold aerobic activity may even expedite not only recovery from persistent post-concussion symptoms, but also even acute concussion symptoms. And so this is work done out of Buffalo, and I'll show you how we think of using this. So back to our return to play progression, which we've used for years when we're returning a student athlete to play. If you have a student athlete who's sort of stuck at light aerobic activity, so they're able, say, to walk, maybe walk the dog, maybe walk up a hill, but anytime they do something a little bit more vigorous, they don't feel well. They get headachy, they get dizzy, they don't feel well. That's a person I would think about. This person may have autonomic dysfunction. This person may benefit from exercise therapy. So looking at this sort of detour off our typical return to play to this new area of rehab. So the work out of Buffalo, they've designed this Buffalo concussion treadmill test called the BCTT, and the details are in your syllabus. The idea, it's like a stress test, so it's very detailed. The athlete is on a treadmill. This can be done by a physical therapist. When I send a patient to have this done with a physical therapist if it's a physical therapist I haven't worked with before, I'll give them the protocol, so I'll print out the paper from Dr. Letty. And it's very formulaic, so it's just like a Bruce treadmill test, except it's for concussion. The protocol's slightly different. But essentially, you're doing an increasing amount of work, and your symptoms are evaluated every minute, as well as your blood pressure and your heart rate. And the idea is that sometimes, as the heart rate goes up, the symptoms will increase. And a positive test is when the symptoms increase by 3 points or more from baseline. And what the physical therapist can then do with that information is they can tailor a sub-symptom cardiovascular program using a heart rate target of 80% of that heart rate where they were symptomatic. So I'm walking on my treadmill, I start to feel worse at a heart rate of 150. Let's choose an easier number, I can't do 80% of one, let's say 100. Then I would do my program at a heart rate of 80, which would be pretty mellow. But that's the idea, right? So you design your aerobic exercise program at 80% of the symptomatic heart rate threshold. And gradually, people can then build up their threshold and recover that way. That rehabs the autonomic system. There's also a group of people that you may send to do this, and they actually do well. And that's also really informative because you've now ruled out autonomic problems. So in that patient, if I thought, oh gosh, I really thought this patient had autonomic dysfunction, and the physical therapist is like, no, they tolerate exercise really well, that would cause me to circle back and reevaluate vestibulo-ocular system, primary emotional problem. So to look back at your differential then. All right, so the last case I'm going to present is one of repeat injury. This is a case of SB, who's a 17-year-old high school wide receiver who came in recently to see me for his second concussion this season. So he was injured in November and also in September. He also had one concussion during rugby last winter, which was January 2019. So when he saw me, he was 3 weeks post-injury. He was feeling better. He was 100% back to school, and he was tolerating non-contact cardio without any symptoms. In each of the 3 concussions, he had taken a hard hit. He had no loss of consciousness nor amnesia. He missed a few days of school in each case and really recovered uneventfully. He's otherwise healthy. And so football season's now over, and he came in because he wanted to know if he could be cleared to play rugby in January. So would you clear him? Yes, because he's symptom-free with school and physical activity. Yes, because the benefits of him playing seem to outweigh his risks of repeat concussion and longer-term consequences. C, not for now because of his increased risk for repeat concussion in the short term. Or D, not for now because the risk that repeat injury might cause him to develop chronic traumatic encephalopathy in the long term. right, thank you. Yeah, I mean, there's not a right answer, right, to this question. I mean, I think that it's just interesting to think about this case and think about, okay, well, what do we know? What information can we bring to bear about this? So there are short-term risks to him going back to play. He's had 3 concussions over a less than 12-month period. What do we know about that? What we know is that when you've had a concussion, you're at increased risk of repeat concussion, and it's likely that your symptoms will be worse and you'll be symptomatic for longer. Okay, so that's one data point. So we know that if you clear him to go to rugby and compared to his teammates with no history of concussion, he's definitely a higher risk for getting injured again. What about long term? So what do we know about traumatic brain injury and neurodegenerative disease? We know that multiple studies have shown that TBI increases one's risk for neurodegenerative disease. Sports-related TBI and the relationship to neurodegenerative disease has been a recent focus. And the focus is this body of literature around chronic traumatic encephalopathy, also known as CTE, which was originally thought to be exclusive to boxers and called punch drunk, but now is described in athletes, military personnel, and survivors of intimate partner violence. It's a pathologic diagnosis made at autopsy, having to do with a specific pattern of tau protein deposition, and associated with a chronic progressive neurodegenerative syndrome involving behavioral changes like depression, aggression, and impulsivity, Parkinsonism, dysarthria, and cognitive deficits. And so how do we bring that data to bear on this young person's case? The data we have is it's difficult to draw causality between subconcussive blows, concussion, and CTE. There are no reports of CTE without preceding traumatic brain injury. And so there's a concerning association between participation in collision sports and long-term neuropsychiatric problems. Problem is we don't know the dose-response relationship between the number of concussions and or subconcussive blows and the likelihood of CTE. And so what we need is longitudinal prospective data to understand this more and to help us apply it to individual people. Luckily, there is a big study going on currently involving the DoD and the NCAA. So hopefully in coming years we will know more, but at this time it's hard. We don't know that dose-response relationship. And so my approach to this conversation is framed like this, and this is based on a really great paper that was published over a year ago by Davis Hayes. It sort of outlines a framework of like, how do I talk to a patient about this? So the way I talk to a patient about this is first I think, are there any red flags? So with this case, SB, is there anything that like clearly he can't go back? So does he have ongoing symptoms? Does he have abnormal imaging? And sometimes I will get an MRI in these cases of the brain to look for some kind of structural injury that might preclude return to play. Or are there any yellow flags? So a yellow flag in a case like this, one is that he's had this frequency of injury in a short period of time. He's also younger, and we want to be more conservative the younger the person is. Other yellow flags that he's not exhibiting, but which you might see, you'll see people where they're getting injured with less and less force, and they're getting symptoms for longer and longer, and those are yellow flags. That just means that the next one's going to be even worse. You know, we have to let history guide us. I think it's also critical to elicit and validate the benefits of sports for all people and for this patient in particular, and to really explore for him what are the benefits. We know we're thinking about the risks because we're worried, but also important to think about the benefits. And so what does sport and activity mean to him? What would be the risk of taking him out of the sport? And then to really think about, okay, what are next steps? So clearly if there are red flags, then you need to treat the symptoms. If there are yellow flags, then there are different things we'll do. And in this patient's case, my suggestion was to not play a contact sport for some period of time to give himself a period of time where he would be injury-free. That period of time is very arbitrary. We really don't know, like, well, if you take 6 months off, will your risk then normalize? We don't know. Hopefully we will know soon. But that's one option, is to just give a symptom-free or give an injury risk-free period. Another option is to choose a lower risk sport choose a lower risk position in the same sport. All of these things are possible things to talk to about with this patient. I think as a sports doctor, the key is, try not to take them out of sports. So, all right, you're not going to play this sport, but what is your next sport? And I, have many patients who've successfully transitioned for a period of time from football to track and field and things like that. So often your good athletes are going to be good at multiple sports. All right, so I will leave you with these take-home points. So in your syllabus, there are some resources. And to remind you that history is key. So we talked about key things to look for in the history of a patient with concussion or with suspected concussion. Tools for management, remembering 1 to 2 days of rest, gradual return to work, then sports, return to play only when asymptomatic. Remember to use the term persistent post-concussion symptoms rather than syndrome. And think about the Buffalo Concussion Treadmill Test. And then if you have a patient with repeat injury, to think about that framework, thinking about risks and benefits and how that applies to your patient. All right, I think we have a few minutes for questions, and thank you very much for your attention.